Okay, let's talk about a medical emergency where, well, the clock is always ticking fast.
Yeah, definitely. We're talking about when the body's own defense system, the one meant to fight infection,
Yeah.
it suddenly turns on itself, spirals out of control, and
Mhm.
starts threatening vital organs.
It's a situation that demands, well, immediate recognition and action. Understanding the nuances is just so crucial.
Absolutely critical.
Absolutely. Welcome to the deep dive. Now, this deep dive is a bit different. We've tailored it specifically for you based on this stack of revision notes you shared with us.
Yeah, we're zeroing in on one single, really critical topic, sepsis.
Think of us as helping you navigate this material. Our mission is to take these really comprehensive notes you've put together.
And basically distill them,
Yeah.
turn them into a clear, high-yield exploration of sepsis. We want to cover all the essential ground.
From what it is, right through to how it's managed, equipping you with the key knowledge you need, maybe for revision, or maybe just to feel properly informed about, well, a really life-threatening condition.
Tackling complex stuff like this, it can feel a bit daunting, can't it? Especially something with such serious implications.
For sure. But we're going to walk through this material together. We'll pull out the most important bits from your notes, make it digestible, memorable, hopefully.
Okay, let's unpack this then. We're diving deep into your notes on sepsis.
So where did these notes kick us off? What's point one?
They start, quite rightly, with the core definition. Your notes describe sepsis as, well, fundamentally life-threatening.
Okay.
And it's not just having an infection. The key difference, the thing that makes it sepsis, is that it's caused by a dysregulated host response to that infection.
And that dysregulated response, that's really the crux of it, isn't it? The body sort of overreacting
Yeah.
and causing damage itself.
Precisely. That uncontrolled immune response leads directly to organ dysfunction. It's a rapidly progressing, potentially devastating process.
Okay.
The official definition, the one updated in 2016, it emphasizes life-threatening organ dysfunction caused by a dysregulated host response to infection. Simple as that, but profound.
And the notes mention septic shock, too, as a kind of subset.
Yeah, exactly. It's a more severe category, defined by really profound circulatory and cellular and metabolic problems. Needing vasopressors to keep blood pressure up and having elevated lactate even after giving fluids.
So sepsis is the big emergency. Septic shock is the absolute worst end of that spectrum, needing even more aggressive help.
That's it.
The notes also mention the 2017 update to the Surviving Sepsis Guidelines, how they dropped severe sepsis.
Yes, they streamlined things. Just sepsis and septic shock now. Makes it clearer.
And those guidelines, they brought in the Quick SOFA score, QSOFA.
They did. It's mentioned in your notes. A rapid bedside tool, really designed for identifying adult patients outside the ICU,
Right.
who have a higher chance of having poor outcomes from their infection. It's simple. Looks at respiratory rate over 22, any altered mentation, or systolic blood pressure under 100. Just those three.
Easy to remember.
And the Surviving Sepsis campaign itself, that's a huge global effort, all aimed at improving diagnosis, management, ultimately trying to cut the death rate from sepsis.
Got it. Definition, key terms covered. So what actually triggers this whole chain reaction? Where do the infections usually start? Your notes talk about etiology.
Primarily, sepsis is marked by infections. That's the trigger. Your notes correctly say it's most often bacterial.
Right.
But importantly, it can also be caused by viruses, fungi, even parasites sometimes.
And it's when these bugs, these pathogens, set off that out-of-control immune reaction we talked about.
Exactly. And the source, well, could be anywhere. Lungs, think pneumonia, urinary tract, abdomen, skin, soft tissues. Basically, anywhere an infection can get a foothold.
Makes sense. Now, who's more likely to get it? Who's most vulnerable?
Yeah.
Your notes list quite a few risk factors.
Yeah, they highlight that a weakened immune system is a major one, whether that's from an underlying disease or maybe medication like steroids or chemo. Advanced age is another big factor, and chronic illnesses, diabetes, kidney disease, liver disease, things like that. Recent surgery or invasive procedures also bump up the risk.
I see the notes also include things like being in hospital for a long time, alcohol misuse, skin injuries like burns,
Yes.
certain meds, as you said, high-dose corticosteroids or chemotherapy. And there's an interesting bit about gender. Males may be more prone, but females potentially facing higher mortality if they do get it.
That's in there too. Also, IV drug use, pregnancy is noted as a risk factor, and having indwelling medical devices, catheters, central lines, their potential entry points.
That's a pretty comprehensive list. Really underlines that while, sepsis can hit anyone, some people are definitely at higher risk.
Absolutely.
So we know what it is, who might be more likely to get it, but how does it actually wreak havoc inside the body?
Let's look at the pathophysiology from your notes.
Okay, this is where that dysregulated immune response really comes into play. The notes describe this sort of cascade. It starts with the body reacting to the pathogen, as it should, but then it just goes overboard.
Exactly. Instead of being contained, it triggers widespread systemic inflammation all over the body.
So it's not just the infection itself causing all the problems, it's the body's reaction to it.
That's a huge part of it, yes. This systemic inflammation leads to damage to the lining of blood vessels, the endothelium. They start to leak.
Leaky vessels. Not good.
Not good at all. This leakage messes up blood flow, disrupts oxygen getting to tissues and organs, and ultimately that results in organ dysfunction. Your notes mention other complex things involved too, like abnormal blood clotting.
That's the DIC thing, disseminated intravascular coagulation.
That's the one, where the clotting system just goes completely haywire. Also endothelial cell dysfunction and the release of loads of inflammatory signaling molecules, cytokines. It's a storm.
It sounds incredibly complex, a multi-system failure, really. The notes also mention things like immunosuppression and mitochondrial dysfunction as areas people are still researching to understand why the response goes so wrong.
Yeah, which just shows it's still an active area of study. Understanding the why is key. Now, because the symptoms can be, well, pretty general at first, it's really vital to think about other conditions, things that might look similar initially. Your notes cover the differential diagnosis.
Right. They list important ones like viral or bacterial pneumonia, UTI, urinary tract infection, meningitis, maybe pancreatitis, all serious things themselves.
And they can definitely mimic some early signs of sepsis. So careful assessment is absolutely essential to figure out what's really going on.
Ruling those out, or maybe identifying one as the source, helps confirm if sepsis is the bigger picture.
Exactly. Pinpointing the source and confirming if sepsis is the driving issue.
Okay, shifting gears slightly.
Yeah.
How common is this? Let's look at the epidemiology section in your notes.
In the UK, the notes really emphasize that sepsis is a major health burden. It particularly affects older adults and, as we said, those with pre-existing health problems.
And globally, the figures you've included are quite stark, especially for kids.
Yeah, the data shows roughly 22 cases of childhood sepsis per 100,000 person years worldwide, and over 2,200 cases of neonatal sepsis, so in newborns, per 100,000 live births each year.
That neonatal figure is incredibly high, really highlights how vulnerable they are.
It does. Your notes also give numbers for high-income countries generally, around 19.4 million cases and about 5.3 million deaths every year.
Goodness, 5.3 million deaths a year globally. That's huge.
It's massive. And the notes wisely caution that even these figures probably underestimate the true impact, especially in lower-income countries where, healthcare access and reporting might be limited.
Right, the true scale could be even bigger. Okay, so it's common, it's serious, and it can be tricky to spot early on. How do we actually recognize it clinically? What are we looking for when we see a patient? Your notes detail the clinical presentation.
Well, the classic warning signs are in your notes. Changes in temperature, and that can be a fever or actually an unusually low temperature, hypothermia.
Okay, either end of the scale.
Exactly. Other signs: rapid heart rate, that's tachycardia, rapid breathing, tachypnoea, confusion or any altered mental state, decreased urine output, and low blood pressure, hypotension.
And signs specifically pointing towards organ dysfunction. Those are key clues too.
Yes, absolutely critical clues. The notes correctly stress that while you have to be really vigilant for early signs, the symptoms themselves can be quite non-specific.
Meaning they could be lots of other things too.
Precisely, which again highlights why you need a really thorough assessment.
The notes mention checking things like respiratory rate, O2 sats, temperature, blood pressure, pulse, and level of consciousness. Those are the key vitals to monitor.
Yeah, and for adults in the UK, the standard system mentioned in your notes is the new WS2 score, the National Early Warning Score. It helps standardize how we spot deterioration, including potential sepsis.
Oh, okay.
And there are specific tools mentioned for children too, like PUWS, Pediatric Early Warning System, and specific considerations for pregnant women. These scoring systems basically flag up patients who need an urgent review, pronto.
So once sepsis is suspected, what tests are essential? Your notes have a list of investigations.
Blood cultures are absolutely crucial. Top of the list, The notes recommend taking at least 2 sets from different sites.
Before antibiotics, if possible.
Yes, ideally before starting antibiotics if you can do it quickly. That gives the best chance of finding out exactly what bug you're dealing with. Then you need a full blood count looking at white cells, platelets, blood chemistry electrolytes, kidney function, liver function tests, and coagulation studies, checking clotting times.
And imaging often comes into it to find the source, like a chest x-ray for suspected pneumonia, or maybe an ultrasound or a CT scan if you think it's abdominal.
Exactly right. Plus, specific tests to check how organs are doing creatinine for kidneys, bilirubin for liver, for instance. Urine dipstick and culture are vital if you suspect a UTI.
Okay.
Glucose measurement is needed. And a clotting screen, including D-dimer and fibrinogen, that's important too, especially if you're worried about DIC.
And the notes list some more advanced tests like venous oxygen saturation, SVO2, and arterial blood gases, which critically includes measuring serum lactate.
Ah, yes, lactate. That level is a really, really powerful indicator in sepsis. Your notes flag that an elevated lactate, typically 2 millimole or more, is a sign of hypoperfusion tissues not getting enough oxygen. It's a definite red flag.
Okay, so lactate is key.
But the notes wisely add, while you need all these tests, they should never delay starting treatment, especially if the patient is clearly very unwell. Get treatment going while the tests are pending. Urgency is paramount.
That urgency really comes through again and again in the notes. And speaking of urgency, the notes lay out a clear way to stratify risk using red flag and amber flag criteria. These seem key for deciding how fast someone needs intervention.
Absolutely essential. The red flag criteria signal a high risk of dying and need immediate action. We're talking within minutes. Your notes list signs like being unresponsive or only responding to voice or pain, new acute confusion. A systolic blood pressure of 90 or less, or a big drop of more than 40 from their usual baseline. Heart rate over 130, respiratory rate 25 or more.
Plus, needing oxygen just to keep SATs above 92%, a non-blanching rash, or looking mottled, ashen, or cyanotic,
Yeah.
not passing urine for 18 hours or very low output.
That lactate level of 2 or more we just mentioned.
Right.
And having had recent chemotherapy, if any one of those is present, it's a red flag response, full speed ahead.
And then there are the amber flags, indicating increased risk, needing urgent assessment within an hour, but maybe not quite the immediate life threat of a red flag.
Exactly. These include things like relatives being concerned about their mental state, any acute decline in function, being immunosuppressed.
Having had recent trauma, surgery, or an invasive procedure in the last 6 weeks.
Respiratory rate between 21 and 24, systolic BP between 91 and 100, heart rate between 91 and 130, or a new arrhythmia, no urine in the last 12-18 hours, temperature below 36 degrees C.
And any clinical signs of a wound, device, or skin infection.
So these flags, from your notes, they're crucial screening tools. They help quickly spot potential sepsis risk and prioritize how fast the clinical response needs to be, which leads us neatly into management.
Right, the management strategy. In the UK, heavily emphasized in your notes, based on the Surviving Sepsis campaign, it's all about rapid, structured intervention, getting broad-spectrum antibiotics and fast fluid resuscitation, supportive care to keep organs going.
Early recognition, timely treatment, they aren't just nice ideas, they're absolutely life-saving imperatives.
And this is where the Sepsis 6 comes in, right? That bundle is like the cornerstone of initial management. 6 things to do within the first hour.
The Sepsis 6, yes. Let's pull those steps straight from your notes. First, give high-flow oxygen.
Okay.
Second, take blood cultures.
Before the antibiotics, ideally.
Third, give intravenous antibiotics, broad spectrum initially.
Fourth, give intravenous fluid resuscitation. Get those fluids in.
Fifth, measure serum lactate. There it is again, reinforcing its importance.
And sixth, monitor accurate hourly urine output. Keep a close eye on kidney function.
Those 6 steps are the immediate priority, that critical first hour. Your notes also mention the full SOFA score sequential organ failure assessment.
Ah, not the QS-SOFA, the full one.
Right. Used later for a more detailed look at organ dysfunction and risk stratification. It builds on that initial QS-SOFA screen.
And for managing the really severe and severe sepsis, septic shock, the notes detail specific therapies.
Yes. Starting with those broad-spectrum IV antibiotics targeting the likely bugs. Maybe considering antivirals or antifungals if you suspect something non-bacterial, but avoiding unnecessarily long combination therapy.
Fluids are key too.
Fluid resuscitation using crystalloids is standard, maybe albumin if needed. The aim is to restore blood pressure and tissue perfusion.
And if fluids aren't enough,
Then vasopressors come in to squeeze the blood vessels and support blood pressure. Typically, noradrenaline is the first choice, adrenaline or maybe vasopressin as alternatives.
dobutamine gets a mention too, for heart support.
Yeah, might be considered if there's evidence the heart isn't pumping well or if there are still signs of poor perfusion despite enough fluids and vasopressors.
And steroids, hydrocortisone.
Importantly, the notes advise against using IV hydrocortisone routinely, only if fluids and vasopressors aren't enough to stabilize the blood pressure.
Got it.
Other crucial supportive measures noted include mechanical ventilation, often with PEEP positive end expiratory pressure if the patient develops ARDS, acute respiratory distress syndrome, that's a common lung complication.
Right.
Managing blood glucose with insulin is vital, providing DVT prophylaxis, preventing blood clots, and stress ulcer prophylaxis. Early nutrition is also important.
And critically, dealing with the source of the infection itself. That might mean surgery, right? Draining an abscess, removing infected tissue.
Absolutely paramount. You have to control the source.
It's good to see that these structured approaches actually work. Your notes mention that implementing sepsis programs based on these principles has shown significant drops in mortality, like 10–20%, and shorter hospital stays too.
Yes, the evidence supports it. The core elements are always early diagnosis, risk stratification, getting those antibiotics in quickly, effective source control, and optimizing blood flow and oxygen delivery.
Okay, let's turn to the likely outcome, the prognosis. Your notes say it varies a lot.
It really does. Heavily influenced by what caused the infection in the first place, how quickly effective treatment was started, and the person's general health before they got sepsis.
Severe cases, though. Unfortunately, they are definitely life-threatening. The UK mortality rate cited in your notes is, well, it's pretty sobering, 35–40%.
That number really drives home the severity, doesn't it? But the crucial point, also from your notes, is that early and effective treatment, especially if it's delivered within 6 hours of recognition, significantly improves survival rates. Time is critical.
And that elevated lactate level pops up again as a strong predictor of mortality.
It does. It's a consistent marker.
And sadly, older adults often face a tougher time. Higher long-term mortality even if they survive the initial illness.
That seems to be the case, unfortunately. The recovery can be longer and more complicated.
Even for those who do survive the acute phase, complications are common, and they can really impact recovery. Your notes list several potential issues.
Yeah, acute complications include, well, the progression to septic shock itself, multiple organ failure affecting different systems, ARDS affecting the lungs, as we mentioned, and acute kidney injury or failure.
Disseminated intravascular coagulation, DIC, that chaotic clotting thing again.
Yes, that's another one. And adrenal failure, sometimes called Waterhouse-Friderichsen syndrome, if it's linked to meningococcal sepsis.
And there's something increasingly recognized, mentioned in your notes, post-sepsis syndrome.
Yes, very important. This describes the ongoing physical, psychological, and cognitive problems that survivors can face during recovery.
What kind of things?
It can manifest as, persistent weakness, feeling breathless, fatigue, joint pain, anxiety, depression, even trouble with memory and concentration. And these issues can sometimes last for months or even years.
Wow. That really highlights that just surviving the initial crisis isn't necessarily the end of the road for many people.
No, recovery can be a long and challenging process.
Well, we've definitely navigated through the comprehensive territory of your notes. We've covered the definition, the causes, the risk factors, how it disrupts the body,
What else it might look like, how common it is, how we spot the signs, the key tests.
the urgent management, the prognosis, and those potential long-term complications. Quite a journey.
So to kind of wrap up this deep dive, let's just quickly hit the absolute key takeaways from your notes again. Sepsis, life-threatening, caused by a dysregulated immune response to infection, leading to organ dysfunction.
Early recognition is everything, using tools like QSOFA, the UK's red and amber flags. And once it's suspected, urgent action with the Sepsis 6 bundle within that first hour is absolutely critical.
Remember that elevated lactate level? It's such a vital indicator of severity and poor tissue perfusion. And while immediate aggressive management is the focus acutely, your notes remind us that complications and long-term issues like post-sepsis syndrome are real possibilities afterwards.
So what does all this mean for you listening? Having gone through these details from your notes, it's not just about learning facts for revision, although hopefully it's high yield for that. It's about really understanding a condition where fast, informed action can literally be the difference between life and death.
Yeah, this knowledge empowers you to appreciate the gravity, the complexity involved in spotting and managing sepsis.
As a final thought, drawing from the breadth of your notes, maybe consider the sheer scale of sepsis globally, especially the disproportionate impact it has on vulnerable groups like children.
Or think about that long-term struggle for individuals living with post-sepsis syndrome. Your notes really highlight that this isn't just an acute medical event. It's a broader public health challenge, a societal challenge that goes way beyond the initial hospital stay.
Absolutely. We really hope this structured walkthrough of your notes has been genuinely helpful, whether for revision or just deepening your understanding of such a critical topic. Thank you so much for sharing your notes with us and for joining this deep dive.
And if you are looking for more resources, especially for exams like the MSRA, passthemsra.com is a really valuable platform. Lots of comprehensive materials there.
And don't forget, freemsra.com also offers free resources specifically designed to help you prepare. Definitely worth checking both of those out.